TopMedTalk.
Welcome to TopMedTalk. You may have heard of telemedicine, but have you heard of TeleICU? And how does it work? What's it like to work in a TeleICU? How do you avoid alarm fatigue? And hypothetically, what level of scale can this technology be safely extended to? On today's TopMedTalk, we revisit a piece which was part of our coverage of Anesthesiology 2022, where we spoke with Mike Scott, Professor of Anesthesiology at the University of Pennsylvania, here in conversation with Desiree Chappell, Monty Mythen, and Sol Aronson.
Our next guest, Dr. Michael Scott. Hello, Michael. How are you?
Good morning. Yes, I'm good, thank you.
First of all, tell us a little bit about your background.
I trained in the UK and Australia, went through actually boarding in medicine before going to anaesthesia critical care, and then threw in a paediatric fellowship in critical care for
I didn't
good
know
measure.
that.
It's a big nutshell.
Yeah. For 15 years, I was involved with European and UK Resus Council, and also then developed the ERAS guidelines in my centre back in the UK, and helped develop that and grow that in the UK with Monty. Then came to the US in 2016, and I first went down to Virginia Commonwealth University Hospital, and now, just in time for COVID, I moved up to the University of Pennsylvania in Philadelphia to take the division chief job there in critical care, and also I head up the TeleICU service, which is we call Pen Alert, which with the pandemic has been very busy, hugely successful, and game changer, I think, in the way that the technology is now being embraced and adopted.
How long ago is it since your team in Guildford published the series of less than 24-hour stay for they were hemicolectomies?
They were all comers, actually. They were including low anterior section with TME. And it was a consecutive series where we sent people home to within 23 hours.
Ambulatory surgery centre.
And
how many readmissions?
None.
Yeah.
We published that in 2009, but we're actually doing it in 2003.
Okay, so coming up on 20 years.
20 years, yeah.
Yeah,
Is
so
that how
maybe
they
people
still
are ready
do it
for
there?
it.
Is that how they still do it there?
Yeah, nothing's changed, and the great news for me is that I've moved, and it's like 6 years on, and it's still going. There's no changes. And also down in Virginia Commonwealth, we've still got the ERAS program there. We've got flow-directed fluid therapy, opioid-sparing ERAS programs, and it's still going well there.
So we entitled our session today, Creating High Reliability in Your Organization Using TeleICU. Let's go ahead and dive into this concept of TeleICU. Tell us a little bit about this article that you had just recently published in the New England Journal of Medicine and what TeleICU actually is.
It's highly topical at the moment. We saw the great adoption of not just TeleICU, but telemedicine during COVID. For instance, at Penn, we were doing something like 54 consults through telemedicine before COVID. Oh, wow. And within, I think, 4 weeks, they ramped it up to over 8,000 a day.
Oh, gosh.
The TeleICU program was established, but we grew it right across the organization and other hospitals like Princeton, New Jersey, and Lancaster General and Chester County. And we actually had to redevelop the whole ICU system because we moved from the Philips TeleView system and built the Epic platform with Epic and put in some new cameras using something called Care Agility platform. And that enabled us actually to take TeleICU anywhere there is a Wi-Fi signal. Okay. So to give you an example of that, my Christmas present from my chief medical officer on Christmas Eve 2 years ago was the fact that we had no ICU beds left in Philadelphia, and we had a COVID outbreak in one of the ventilator sniff facilities with about 54 people ventilated. So we actually took iPads, and within 6 hours we had established a two-way link to our respiratory therapist to support the RT in the sniff facility with the support of a APP service, a MD service centrally going out to these centres. So I think we've had a complete game changer in technology. Yes. So it might be best I just describe how our TeleICU platform works. So there's different models in the US. Some people have TeleICUs which actually directly change care on patients remotely. Okay. Obviously for TeleICU we need two-way audio and video link. You need to be able to get into access the EMR. And you need some sort of way of calling for help, which can be just simple messenger, texting, phone, or we have a button on the wall as well for emergencies. So if you want to prescribe stuff, then you can do it through the EMR. We have a slightly different model at Penn because We are more like the air traffic control model. And it's all about building high reliability into the health system on the grounds that no health system is perfect. And you're only as good as your weakest link. And your weakest link is often during the evenings and weekends and nights when there's less bedside providers and the staffing ratios go up. So we have a system which is both proactive and reactive. So the reactive system is, as you'd expect, bedside provider has a problem, presses a button, and immediately gets us into the room, and we can support them with, we have 4 nurses, we have a 24/7 APP, we have nighttime MD, and we have a respiratory therapy as well. So they can then go in and support, but we're rarely actually going in, obviously, to change things. It's more about getting the right resources to the patient at the right time and accelerating that, and obviously prompting the immediate decision-making. So that's the reactive side, and we've built a whole set of best practice advisories as well in the EMR, which are very smart. And we have about 3 million algorithms running every day on all our patients, of which probably the TeleICU service reacts to about 1,000. And as technology has improved, we managed to get down all the false alarms and build in better and better algorithms.
So, Mike, that's a lot of information or data that is transferred to information. Operationally, how do you protocolize the pushes and filter out the less relevant data?
Yeah, so out of those millions of firings, a lot of them aren't actually firing because the patient's okay. And then you've got some advisories that come up which are warnings or just advisories. We've tried to take the noise. If you go into our TeleICU, which is downtown in Philadelphia at Rittenhouse, there's about 8 booths, and you'll be amazed how quiet and calm it is, despite the fact there's all these alarms firing, because we took the noise and the distraction out.
Oh my gosh.
For governance, you have to make sure that if an alarm is firing, that our team actually can A, acknowledge it, and B, action it. So we have different types of alarms with different types of acknowledgement, and we can defer that alarm. So if it's not really important, you can just put a pause on it, defer it for some time. But we've also built in algorithmic decision-making trees. So if the hemoglobin drops and it comes up and it's 5.6, that's obviously an important one. So we have a way that we close the loop to make sure that the decision tree is there to support whoever's making that decision, and the information then goes bedside to the provider, so action is taken.
What I'm visualizing is a bunch of people in an air traffic control remote environment getting inputs continuously with built-in algorithms or filters to sort of prioritize or in a hierarchical way what would prompt them to take actions. Is that a fair visual?
Yeah, so it all depends on the urgency, and the action might be they go straight in the room with a 2-way audio visual and talk to the bedside provider, and might be calling another provider like an APP or a physician into the room immediately if it's urgent.
Can I go back to your, sorry, Sol, I just want to go back to your hemoglobin of 5.6 for a second. Just tease that apart for a minute. So if it went from 6.2 trickling down slowly, does it triangulate as opposed to it suddenly went down?
Yeah.
Does it triangulate that with other variables then and say there's a hint of ST segment elevation, the heart rate's gone up, the respiratory rate's increased, saturation's gone down?
It gets complex, but at the moment, our BPAs or best practice advisories trigger mainly off single advisory.
So you've reached a threshold whereby
so it will be a trend
is serious.
Or a threshold, yeah. And it's normally the delta that we're looking for in these algorithms.
Because as a clinician, you turn around and say, well, if it was 8 the last straw and 4 hours later it's at 5.6, this is serious.
Yeah, so that will fire a red alarm, whereas if it's just trickling down, it will be an orange advisory.
Cool.
Or something
You can see how that can go quickly in the future. Sorry, I cut you off, Sol. I just wanted to understand how clever that got.
I could go 2 directions with this, and I think I'm going to go both directions, but I'm going to let you choose which ones you want to grab. The first is, how did the COVID crisis catalyze the momentum of this, and how sticky is this entity now after the crisis to move forward?
So during the crisis, we had to accelerate the TeleICU service in a very short space of time. We did that with mobile devices, mobile carts. We have 550 fixed cameras in ICUs. So Penn has an enormous proportion of critical care beds across
So the cameras
system.
are fixed in the room. They're like CCTV.
Yeah, absolutely.
Cameras.
And they're
fixed
amazing.
in the roof.
Yeah, and you can zoom in on a pump and you can read everything. So, or you can look at the
And
patient.
I'm guessing this is standard operating procedure hereafter.
Yeah, and it's growing all the time, obviously. The game changer was the fact that we could link into not just fixed cameras, but even an iPad, which is how we went into
Oh, right.
a SNF facility. And
Which
within
is
a few
skilled
hours,
nursing facility
Skilled
for
nursing
those who may not
facility.
know.
That's right. I think the exciting thing at the moment with the technology is that we've built the new platform within our EMR, Epic, and it's actually called Epic Hyperspace. And so we've built a parallel universe, actually, with where we've got different dashboards and
Are you
different
the only
ways to
people in
display.
hyperspace at the moment, or is that a new Epic
No,
thing?
it is available, and of course, there's other EMRs are available.
So do you have to have the Epic platform to be able to do what you're doing?
We have built it with Epic within our
that
platform because
ecosystem.
it's the EMR that we interact with.
Right.
Yes.
But the clever bit that we've done, which is unique, is that we've built dashboards so that you can go to the patients that are in trouble quickly, and with single clicks, you can scroll through the dashboard. So you've got an overview
Yes.
and trends, and then you can go into, say, respiratory, or you can go into cardiac.
Yes.
And it will give you everything that's going on with all the data and the trends, and also what infusions they're on, all right there in front of you. And we've actually, because there's not much room on a screen, we have these great big long screens, but even that doesn't help you always. So we've actually got a cube that spins in the middle
So,
to save real estate.
So we're at Epic back at UCL in London now. If we wanted to go to Epic and say we want hyperspace and could we buy the Penn version, it doesn't work that way. Is that right?
No, unfortunately, everyone seems to have to build their own Epic version.
Yes. Let's not get into that here because
No.
we might get ourselves into trouble.
Cry.
You can see why we're not necessarily happy about that.
At the ground level of supervising the monitor that supervises a number of patients in a number of beds, how do you decide what is the appropriate staffing ratios?
We literally have a sieve as things go through. So we have 4 24/7 nurses that take all the ICU beds, and then an APP that takes another group of patients. So they have about an 80-to-1 ratio, which is high. It's higher than most
Very high.
tele-ICUs.
And then in the person who's in air traffic control, how many planes can they watch at a time on their radar screen?
About 80, and we've set up so that you've got unstable patients that you can have watching you for with all the vitals.
So when you said that there's those 4 nurses, their only job is to monitor?
Well, they do monitor, and they do a lot of other things like check compliance with best practice, and they're all skilled ICU nurses. So they know, they have that sort of sixth sense when patients are at risk or deteriorating. And then it gets basically escalated to an APP or the MD or the RT, the respiratory therapist, as appropriate.
So this is a what do you think question, but the applicability of this theme to OR management.
So the next stage that we have done at Penn is we have managed to build a gateway through our monitoring system and capsule so that we can send any waveform live within 3 milliseconds up to a cloud and bring it back in wherever we want. So we have some of these waveforms coming into the ICUs on the monitor on the wall. So we have
My question was more specific to the delivery of anesthesia in the OR with extenders.
Same model.
Yes, so the same models. I was going to say, so the other thing is you can bring the waveforms actually into Epic through context. So we're linking with the first organisation ever to do that. So then if you're giving anesthesia and you normally just have a trends chart with the anesthesia chart remotely up, we now have a way that you could bring in your actual waveforms on the monitor as well.
I think Mike Sol might be asking, can you run 12 rooms?
Yeah, but that's what I was... that's,
Essentially.
yeah.
Essentially.
So
Or
yes,
20 rooms.
That's exactly right, because what you can then do is put your smart best practice
BPAs.
advisories into your platform. Also, you can adjust these BPAs, so individualize them for your patient. So I think what you're asking me is the potential to have your EMR open with all these different patients and also then have live waveforms in. Yes, we've got that, but we would have to tweak it a bit for anesthesia. That's our next thing to look at.
How many algorithms did you say you had for respiratory therapy? Or to have a whole new set for anesthesia?
It's all about situational awareness, I think, TeleICU. The BPAs are firing and they're always a couple of minutes behind.
Oh yeah, you can't have that in the
Unless
in the OR.
it's something like asystole or
You think
something
humans
like
aren't a couple of minutes behind? I mean, you reported yesterday that you had half an hour of hypotension commonly.
Yeah,
in your,
that's true.
You know,
Well, no. I mean, you can see
not
things.
you individually, Desiree. Those who didn't hear it,
I'm
a big
perfect.
study that was done in 2 organisations that
But
demonstrated
that is exactly the potential we can do now.
can
We can
avoid that.
build your BPAs, you can build your deltas in, so that if you've got 20 minutes of even mild hypotension, you could build an advisory in, and that can fire.
Well, I think the thing is, it's people, they see it, they just don't do anything about it.
Well, I
if
think
you have a
in-
BPA firing, that's the clinical decision support.
But to continue to bridge the two applications of a common technology, and you shared with us some data about compliance and adherence to the protocols that you established in your TeleICU respiratory therapy. I mean, you can get over that by just instilling, if you will, those protocols of ensuring compliance.
Oh, yeah, that's right. So really what we're building is, if you think of the proactive and reactive model, enhanced recovery after surgery is just basically a bundle of macros, isn't it? In fact, all good practices, sepsis bundle is the best practice bundle. So if you can ensure that you're compliant with your best practice bundles, and then you can pick up the reactive side early and put the patient straight and fix whatever it is quicker, we know that you get a better outcome. So I think situational awareness with the waveforms is key. So I think that's why we haven't gone live, through the EMR, because although we can have the chart open and be watching what's happening in a room a long way away, you don't really know what's happening until you have the waveforms. So now we've got the connectivity to have the waveforms. I think there is the potential to start looking at how we deliver anesthesia in a different model.
And your paper you were referring to, Mike?
I want to give credit to all my crew at the downtown Rittenhouse and Penn Elet. Chris Ladansky, he's an intensivist that I work with, and he very kindly is working right now so that I could come to the meeting. Thanks, Chris.
Thank you, Chris.
He was first name author in a paper that we got into the New England Journal Catalyst, which was basically the history of the TeleICU respiratory therapy service, because it was the first ever time that we had that service. And it's developed over 2 years to really be part of our whole system of building high reliability. The reactive side, it was built through COVID, and it really was reactive. And we had a huge number of people in downtown, because a lot of people who couldn't work bedside came and worked in the core. Like we had hospitalists, intensivists, medical students, everyone. At one time we had about 18 people in the core through COVID, all delivering care remotely across our health system. And the RT came out of that because a lot of the RTs couldn't work bedside because for health reasons they couldn't have risk of aerosolization. So we built the reactive side, and then we built the proactive side. So the proactive side is part of our key quality indicators now. So we've built things in like just routine rounding to make sure people are on a PPI and DVT prophylaxis. We've got SBT, spontaneous breathing trial nudges, sedation hold nudges.
So these are all like a BPA, like a flag.
Yeah. And then we have safety things like to make sure if the patient is a difficult intubation that we have a difficult extubation process so that
so you're not missing the stuff that starts to get missed as the units get bigger and bigger.
Absolutely. So this is running in the background. And then we have some algorithmic things. So we have something called the ICU board, and in that algorithmic firing, like for ARDS, so we have a bundle where P2F ratio, etc., hits a threshold, and then that triggers an alarm.
I just want to get a bit of context. So for those people who haven't worked in the intensive care unit world, because it's young intensive care, we're sort of like second generation intensivists, believe it or not. How big was the first unit that you worked on? How many beds? The first one you walked into?
My first one was about 8 beds, and that was the whole hospital.
That was the whole hospital, the Middlesex Hospital. 8 beds. How many beds do you have now?
Across the health system,
just stick to one.
We tend to build in 12s in the US because.
And how many is the total in the hospital now?
Across the health system that we've got on the TeleICU, 550 going to 650 shortly.
Yeah. So even in the footprint back in London, we're up sort of 80. Compared to the 8, if you see what I mean.
Yeah, absolutely.
It's a 10x over time. Technology's got to be embraced.
Yeah, I think technology could mean that we could run far more high-level care beds rather than critical care beds. Because we have to hang on to people.
Triage better.
Merging, your experiences of the reactive management, applying them forward to the proactive. with respect to utilization of personnel, some of the things that you're doing or, suggestions should be protocolized as routine. The people who used to be in the core looking at this remotely, are they now transplanted to be on bedside? Or have you figured out how to maximize the utilization of personnel so that you don't need to spread, if you will, the people to be on site, which is a lesser efficient way of utilizing manpower?
Yeah, so at the moment, we haven't changed the ratio of patients to respiratory therapists bedside. But what we've aimed to do is take a lot of the routine, mundane things that they'd otherwise have to do away from them so they can concentrate on actually treating the patients. I think we've had this sort of job creep, haven't we, in healthcare?
Right.
Yeah.
That's
where
why I'm
people
asking.
do more and more. And also we have to document more and more with the EMR.
Yes.
And that's taking a huge amount of time away from people actually delivering the care. So we need to actually make our EMR smart to self-document so that we don't have to take the bedside nurse away from the patient and actually go back to the good old, nursing the patients, getting better.
Let me tell you, it's as a critical care nurse myself, it was so what created so much internal conflict in yourself when all you want to do is be at the bedside, be able to take care of somebody, do all of your assessments in a way that you're not completely rushed. But it's like you got to go back and you got to do all that charting, and you have to, deal with things that don't work, or you have to empty the trash because you don't have, your ancillary staff to help you because no
Straighten the sheets and brush their teeth.
That's it.
Makes a big difference.
Giving a bath. That's the best time that you can take care of a patient.
Okay.
You find them. Mike.
Amazing, Mike.
Yeah, it really is. I want two things. One, adoption by the teams, because we talk a lot about technology here and how it takes so long to adopt new technologies. Obviously, during COVID, there was a need, and I could see rapid adoption. As you go on, constant I'm sure you're getting constant feedback. What is the feedback though from the teams that are using this, especially with nudges? You hear a lot of people in the Epic space, don't add another BPA, don't add another warning or a flag, because you get, you get this creep of people just ignoring everything. It's like alarms.
Yeah, I think the system we run is the air traffic control tower. So we are advising and going in to help and trying to take work away from people. Yeah. Different people do perceive that in different ways. So we do have sometimes pushback from bedside providers who think that we're sort of an eye in the sky and looking over what they're doing. That isn't our role at all. And it's all about education and making them realise that we're working with them. And in fact, when we have watch lists, so if you've got one APP admitting on the medical service and they've got 8 sick patients, they can literally say, can you just look after the DKA and do what you think needed while I admit these two? Diabetic ketoacidosis or something like that. So once they learn how to use us, I think that we're very welcome. We're not just watching what they're doing. It's more centering care on the patient, and especially at the evenings and weekends, which is where we have the most value for the reactive side.
The aviation industry has evolved to not have the relationship between ground traffic control and the pilot be competitive or one of paranoia, but rather a necessity to function at the highest level. That sort of emotional reaction is one that we're going to have to evolve to as well.
I think what is very interesting is that when you do sit in the chair and you've got the eye in the sky, you see patients very differently because you're seeing the trends, and it becomes very obvious that you have the patient in bed 2 is deteriorating.
Right.
Yes.
Whereas when you're on the ICU, as I am as well, bedside, and you're walking up and down, you don't always get that information to you.
Do you think we get to a point, they've done it in radiology, so the idea of reporting during your daytime for X-ray films, which certainly happened in the UK some 15 years ago or so. We did, during the daytime, we did Australia, and at night Australia did ours, if you see what I mean. So they reported the films when they needed reporting, so you didn't have that fatigue factor. Do you think people will start to exploit even the time difference in the USA would make staying up at night a bit easier? A step too far? Or?
No, I think it's already done because there's an Australian group that do TeleICU for other parts of the world.
Yes.
Because they're
in the US yet? Because
I'm not sure, to be honest.
Because kind of makes sense. Everyone works in their daytime.
Yeah.
You've got to have a lot of people to run in the room, obviously, at night, but the eyes on. You can do it. Yeah, great.
Well, Mike, the last thing I wanted to say, I made a couple notes here, was that you said that this technology could be used for higher levels of care, but it's almost like it's a higher level of monitoring, not of care, because it's not
Correct,
necessarily that you need the care, it's that you need the monitoring. And, there's a lot of wearables and different types of new technology and things out there, all of that integrating. Do you have any new monitoring technology that you've integrated now into this?
It's all about the right monitoring for the right patient at the right time.
Agreed.
And when we go for surgery, we're going from the OR, then stepping down into the PACU, and then normally the floor. I think the biggest challenge we have in medicine at the moment is we have this huge gulf between the PACU and the floor, because you're going from continuous
Even in your
blood pressure
shop
monitoring.
now, have you closed that gap yet?
That's what we are trying to work on in the high-level care areas. So we're trying to go to continuous non-invasive blood pressure monitoring, because then you can actually fire BPAs off it. Because if you've only got a 15-minute blood pressure going off, or even a 4-hourly blood pressure, you can miss a lot.
But you don't need a 2-to-1 nursing ratio on that.
Well, the idea is now you've got the wireless technology, all the patients. So you could just literally have 4 patients in each of our hospitals who are deemed high level enough to need continuous blood pressure monitoring, and hook them all up on a watch list and have them centrally monitored downtown by the TeleICU.
I wanted to make sure we capture that again. So tell us again the articles that you've had come out and where we can find those.
Yeah, so it's about the respiratory therapy service. It's in the New England Journal Catalyst in June. And as I say, thanks to Chris Ladansky and Huffenberger.
Is Catalyst open access, Mike?
It is, I think. Yeah. And of course, Bill Hansen, my CMIO as well, I have to mention.
Yeah, absolutely.
And you had some other articles out recently. We're looking at the acute kidney injury data yesterday with the...
Yeah, that's from my previous health system, VCU.
Big financial opportunities to reduce the incidence of post-operative acute kidney injury.
Yeah, basically we looked at all surgical patients, non-cardiac, over the year before COVID, and they're basically the 1-year mortality.
6,000
stages of AKI.
Something patients.
Yeah, about 6,800. Yeah. And we looked at the costs as well. We did a modelling for the costs. No surprises with stage 3 AKI is bad news generally, and stage 2 pretty bad news. But what surprised us was that the odds ratio, if you had stage 1 AKI, is that your mortality at 1 year is 1.9.
So that's what we used to call the creatinine
2.4
bump. In other words,
we ignore these. Yeah, so really there is no such thing as a mild AKI. It all seems to have a downstream effect. And your mortality went up 7%. So again, it's all about, well, which group do you want to be in? And the cost implications, even for mild AKI, were about $4,500.
And some people would say, well, that's just a marker of the fact that they were less well. But you did manage to change the rate of AKI as well, didn't you? So you intervened and you reduced it. So
we did the
2-point harm.
Yeah, 2-point flow-directed therapy optimization after induction of anesthesia before surgery, and then at the end of surgery when the patient's flat and there's no gas in the abdomen if it's laparoscopic. And that had a profound effect on AKI. So we got another paper coming out, and in the highest risk group at the time, which was our colorectal group, we brought down the rate from about 15.5 down to about 7% in that group. But in general, all the AKIs were going down. And it was interesting. We stopped some really severe AKIs, and we got rid of a lot of stage 1 AKIs. But it does seem there's some patients who have poor renal reserve that always are going to have some bad.
Where's that paper?
That one is in the Journal of Clinical Anesthesia, and that is literally coming out. Yeah. It's out online, and it's hard copy in November. So, hot.
Mike, I can't even tell you. Thank you so much for chatting with us again. It's always a pleasure to hear what you're up to and what you've done. Yeah. And thank you for listening to TopMedTalk. We wanted to take this opportunity to thank our sponsors and our supporters for us to be here. TopMedTalk is free, open access to the world. We're listened to in over 100 countries, and that is not possible without that support. The American Society of Anesthesiologists have provided us this amazing booth here in the exhibit hall. It's prime real estate for sure, and we wanted to thank them. We also have platinum sponsors.
We do. Edwards Life Sciences and Medtronic in particular. We've got lots of other great sponsors, but those are our two Platinums and Edwards in particular stuck through us the whole way through.
They got
us going.
They have. We started on the Edwards booth in 2017. So,
And we're greatly indebted to all our sponsors, because without them, we wouldn't be able to fulfill our mission, which is to just give these podcasts and data and educational venues free to everyone in the world who wishes to see them.
yeah,
So
absolutely.
thank you again.
Thank you.
Don't forget, of course, the fuller conversation is available if you check out the show notes to this piece. And don't forget to subscribe to TopMedTalk for more live or as live coverage of conferences in the field of perioperative medicine as and when they happen.
TopMedTalk.
Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.